Welcome to this Beyond Zero e-learning module. This is one of the Wits RHI catch-up sessions. This particular module will be looking at DRTB side effects and focusing on the dermatological, renal and cardiovascular side effects. Dermatological side effects are common. You see them with just about any drug that you can use, and DRTB is no exception. Commonly, as with all drugs, there's always a problem of getting a mild allergic reaction presenting with pruritis, itching, or an allergic rash. And all of our first-line TB drugs are actually quite rashy, so INH, PZA, and ethambutol. And most of the times we can treat through it. So we can use our antihistamines, you can use an hydrocortisone cream that you've mixed with some emollients. And as far as possible, we want to try and see if we can treat through a rash, and it usually settles down. But of course, there are certain scenarios where you should never continue your rashes, and I want to quickly run through some of the important red flags. And these red flags are actually valid for any drug rashes you might see. So number one there is fever. If a patient is presenting with a rash and fever, you need to be concerned. And of course, if they have systemic symptoms as well, such as jaundice or vomiting, an ill patient with a rash must always ring a big bell. Any mucosal involvement makes us concerned about an early Stevens-Johnson syndrome. So those are lesions on the mouth, lesions on the genitals. And blurred vision is actually part of that picture, that you can have lesions on the conjunctiva of the eye, and that can be an early warning sign of worse to come. The kinds of rash we don't like is particularly what we call a non-blanching rash. So it's a rash that almost looks like a bruise, or a target lesion rash where you can't actually press away the color of that rash. Any of these red flags means we have to stop the drugs, wait for the rash to settle down, and then depending on how severe the reaction was, you would have to decide whether it's worthwhile to re-challenge. Injection site pain is probably one of our most common issues and can be one of your biggest obstacles for patients to return every single day for their injection, and there's no easy solutions to this. So there has been indications that if you pre-medicate with ibuprofen or Panado, it might help. But unfortunately, there are no studies on the use of combining Kanamycin or amikacin with lidocaine. So what we don't know is whether this might affect the actual pharmacokinetics of the drug. And there is a PK study currently in progress in Cape Town that perhaps can give some light on this, but at the moment it's not recommended. We also need to keep a very close eye on the sites of the injections, because if there's any infection, one can get quite severe injection site complications. And certainly you want to pick up problems before it deteriorates to this point. Skin discoloration is something we're going to see more and more now that we have clofazimine in our new regimen. So if you think of clofazimine, you need to think orange. And it can pigment the conjunctiva, the cornea, it can body fluid. We say orange, it can be a reddy color or a brownish black color, depending on what the person's underlying coloring already is. And of course, this can be very stigmatizing and very concerning from the patient's point of view. It recovers after the drug is stopped. And it can be made worse by sun, so it's quite important to advise that they use sunscreen from the moment that they start on treatment. Patient education here is very, very important. The patient needs to be aware of this before you start the drug, and need to be prepared for it, or they will stop the medication. Renal complications is an important and potentially very serious complication of DRTB treatment. Our number one culprit for renal impairment is, of course, our injectables, Kanamycin in our adults, amikacin in our children, and it's essential to do that baseline creatinine, urea, electrolytes, as well as magnesium and calcium, and of course your EGFR. And then during the injectable phase, we need to monitor that creatinine and electrolytes very closely. Important not only take the bloods, but to follow up on the blood results. As soon as that creatinine is over 100, it's essential to calculate your creatinine clearance and to classify that renal impairment to help you make a decision about what to do next. So let's say a few words about creatinine clearance. Your creatinine clearance calculation is similar to your EGFR calculation. They're all trying to approximate the GFR, and so therefore to be able to see if your particular creatinine level in that particular patient is high or normal. The challenge is there is more than one calculation, and there's more than one version of each calculation. So the one we are the most familiar with is the Cockcroft-Gault calculation. It's the one you will see in the DRTB guidelines as well as in our national consolidated ARV guidelines. The problem is you will notice there are different versions with different numbers when you look at the formulas. And it is because some of the formulas are using milligrams per deciliters, and some of the formulas are using micromoles per liters, and it's not always clear. So, for example, the one in the national ARV guidelines seems to be the one that's using milligrams per deciliters. The result that we're currently getting from the NHLS is usually in micromole per liters, and therefore I've put here the formula that is still the old-fashioned Cockcroft-Gault. For the men there, 140 minus the age times weight times 1.22 divided by the creatinine. In women, the same formula, but you using 1.04. But if you go and look in terms of the validation of the formula, you will find that the Cockcroft-Gault is actually no longer seen as the gold standard of formulas, and there are other formulas that is now seen to be much more up-to-date and much more valid. To find these, you can go to your EML clinical guide. It's an app that you can download, and on them they've got calculators that you can use. And the better formulas is now called the CKD EPI formula or the MDRD calculation, and both of those are in the EML app. They're quite complicated, not so easy to do on your local calculator, and I would recommend both downloading the app for all the other features it has, but certainly makes this calculation easier. If you need to make a decision about, for example, adjusting dosages using the CKD EPI calculation is the best one to use. If you don't have access to the app and you don't have access to these particular calculators, then this is the Cockcroft-Gault formula that you need to use. Once you have your creatinine clearance or your GFR, you need to be able to stage the kidney disease. And please note that a normal GFR is well over 90. So although the calculation done by the NHLS for us will always say the GFR is over 60, it's simply because that formula is not reliable in the higher levels. So you can see there, once your GFR is under 60, you already have stage 3 kidney disease. But we are quite comfortable with kidneys having to only be under a GFR of 50 before we have to consider, for example, changing to Whenever or adjusting our dosages. So let's say you have a patient with DRTB with a high creatinine. How do we manage those patients? Important to repeat your urea, creatinine, electrolytes, magnesium and calcium. Sometimes it might just be a pre-renal strain on the kidneys. The patient might have been dehydrated, or the patient might have had a sepsis. If the patient is still on tenofovir for whatever reason, get them off onto either abacavir or AZT. In our other presentation, we speak about that in more details. And make sure you take the pressure off the kidneys. So look for fluid overload, make sure you advise on fluid intake, check for edema, record your blood pressure and pulse for future follow-up. And you have to now look at your dosing of your injectable. Are we going to reduce the dose? Are we going to reduce the interval? And we now have bedaquiline available, so we would probably be changing these patients to bedaquiline. Very important, if that GFR is under 50, we have to adjust all renally excreted medication. And the simplest is just to call up your medicine information center, go through the list of all the medication this patient is on, give them your calculation of that GFR, and ask them on which dosing they need to be. This is an example of some of our DRTB drugs that will have to be adjusted. So, for example, PZA dosing will have to come down depending on the creatinine clearance. The ethambutol doses might have to be adjusted, as well as ethionamide, and do this under advice from your medicine information center. We need to spend a bit of time on the cardiovascular risk with the MDR-TB drugs. Luckily, a fairly low risk, but because this risk can increase mortality, it's very important that we are vigilant. Our big concern cardiovascular is the arrhythmias, and particularly the lengthening of the QT interval, which may very well lead to heart block and could present with sudden death. Our big concern there is bedaquiline, and although it's a relatively rare effect, the problem is you're combining it potentially with other drugs that also increases the QT interval, such as moxifloxacin and clofazimine. If the patient is starting to develop arrhythmias because of this lengthening of the QT interval, they might present with dizziness or fainting or palpitations. But the majority of these patients will be asymptomatic, and it's therefore important that we have regular ECG monitoring to pick up this early prolongation of the QT. And you can see if a patient is on their 6-month course of bedaquiline, they're actually going to have 8 ECGs during that time. So once at baseline, 2 weeks, 4 weeks, 8 weeks, 12 weeks, 16 weeks, at 20 weeks, and then at 24 weeks. One of the recommendations is that we do not use therefore bedaquiline with moxiflox. Levofloxacin may also increase the QT interval, but not nearly as much as moxiflox. And so moxiflox and bedaquiline is contraindicated together. So how do we count that QT interval, and what does that look like? If you remember, our ECG paper is divided into blocks. It's got small squares and it's got larger squares. The smallest square there are 1 millimeter by 1 millimeter. And your ECG is recording on paper at a standard 25 millimeters per second. So what you need to remember is that each little block represents 0.04 seconds or 40 milliseconds. Once you know that, you can now count how many blocks there are between the beginning of your Q wave and the end of your T wave. This slide gives quite a nice example of what you do if your T wave might not meet the baseline. Sometimes the T wave is quite lifted, or there's a U wave that makes it confusing, and you can use your tangent there to see where the T wave would have crossed the baseline. So you count all the little blocks between the Q and the T, and in this particular example, there's about 8.5 blocks. And then you times it by your time factor of each block. So times it by your 40 milliseconds, which will give you 0.34 seconds, or 340 milliseconds between the beginning of the Q and the end of the T. Unfortunately, this is not the end of the calculation, as it has to still be adjusted for the heart rate. So the QT interval will vary depending on how fast your heart is beating. You can use that nice complicated calculation there. That's called the Pruritis method. Much easier is to download the app. I've got down there the logo of the QX calculator application, available for both iOS and Android. And it's got lots of calculations in it, not only the QT corrected calculation. And you'll simply enter your amount of milliseconds, so 340 milliseconds, plus your heart rate, and that will give you a standard corrected QT interval. Once you have your corrected QTcf interval, you now need to decide whether it's normal or abnormal. And basically, if it's under 470 milliseconds, we are fairly reassured. In males, it's normal less than 450. It's women less than 470. But even if in males it's slightly up, we at that stage would just observe. Once it is over 500 milliseconds, that's definitely a lengthening of the QT interval, and that is definitely a concern and is putting the patient massively at risk. The ones that's confusing is when the interval is sitting between 470 and 500, and certainly all of those patients you will discuss. If there is an increase of the QTc interval, you have to do something. So you'll have to either look at withdrawing the drug or looking at the dosing, and you certainly will be discussing all of those patients. So to summarize what you would do when you see an increased QT interval, is the first thing is to repeat your ECG and just make sure it is prolonged. Before you start considering discontinuing the bedaquiline long term, it might be useful just to check if there's not other contributing factors. So particularly your electrolyte abnormalities. So check your potassium, your magnesium, and your calcium. If that QT interval is over 500, you might have to stop the bedaquiline while you wait for your electrolyte results and until your electrolytes have actually normalized. If the QTc is slightly up, but it's under 500 milliseconds, you can keep just an eye, but you'd have to do weekly ECGs. And as soon as the QTc interval is over 500 milliseconds, confirmed by repeat ECG, then we're going to have to discontinue all QT prolonging drugs, which could make treatment quite a challenge. Thank you. If you've not yet done so, please check our first module in this series on the side effects of the nerve sense system, as well as the musculoskeletal and abdominal and metabolic systems. Also see our next module, which will be focusing specifically on monitoring and counseling on the side effects of DRTB treatment.